Now let's start with the opening session with welcome remarks from our hosts, the National Institute of Malariology, Parasitology and Entomology, also in short NIMPE, from Vietnam, followed by remarks from APMEN. So our first speaker today is Professor Dong, Director of the National Institute of the NIMPE in Vietnam. And Vietnam, as you all know, is also our host. So Professor Dong has worked for many years in the Ministry of Health in Vietnam on the control of infectious diseases, including scientific research on malaria and parasitic diseases. He is also responsible for overseeing the Global Fund supported Regional Artemisinin Initiative, or the RAI program in Vietnam, and is also an associate professor and doctor of medicine with teaching positions in 2 medical universities. He's an active participant in collaborative activities with many organizations, as you can see on the slide WHO, APMEN, ACT, Global Fund, APMEN, and also the US CDC. So I will hand over to Professor Dong. Over to you. So I don't hear Professor Dong yet. Professor Dong, are you there? So it seems that he's not online yet. He might have a technical problem. Yeah. Professor Dong?
Yes.
Ah, wonderful. Professor Dong.
Good afternoon, distinguished leader, ladies and gentlemen. Warmly welcome to APMEN country partner, represented from officials from the 22 national malaria program across Asia and the Pacific, representatives from APMEN partner institutions, including implementing partner, academic and research institutes, civil society organization, university, community-based organization, and the private sector. Vietnam's progress toward malaria elimination. The government of Vietnam remains committed to the 2030 goal of the eliminating malaria from Asia and the Pacific. Vietnam has seen an almost 90% decline in malaria cases since 2010. Is now part due to the availability of the essential malaria commodities, particularly long-lasting essential in high-risk populations. In addition, the utilization and appropriate diagnostic has reduced in the likelihood in misdiagnosis and inappropriate treatment and antibiotics. The threat we face with artemisinin resistance developing more broadly in the greater Mekong sub-region has been reduced to a great extent through coordinated with action with national malaria program in the region through the regional artemisinin initiative RAI. The RAI is now entering its third phase. We need to accelerate effort to eliminate falciparum malaria by 2025. A set to radical cure for the relapsing malaria virus is critical as 36% of the confirmed cases in Vietnam are now due to virus. APMEN annually meeting and Malaria Week 2020. Vietnam has experienced significant gain toward malaria elimination over the last 10 years. This has been made possible due to the resonant platform like APMEN that allow for the coordination, sharing of information, and the best practices, and providing access to native development and innovation, whether the related to the vector control or radical cure for the virus. Vietnam has been a member of APMEN since 2012 and collaborates with the network through the 3 working groups. The APMA dashboard is important tool for the government officials and partners to check progress in the region toward elimination. The technical annex of the dashboard provides a snapshot of progress with data from the World Malaria report and support Malaria program manager with information on the key priority in terms of high burden area and help to inform decision making by the National Malaria Program. The next 10 years will require strong multi-sectoral partnership that includes strong engagement with the private sector and community-based organizations. We are glad to see this year the APMEN annual meeting is focused on the exploring alternative model of the engagement with private providers and CSOs. The APMEN platform provides an opportunity to share the country experiences and support country-to-country collaboration, especially in reaching the hard-to-reach population. Our experience with COVID over the last 6 months has highlighted the importance of the partnership between the public sector and private sector and civil society. We have seen the strong role played with the community health workers and private providers in creating awareness around COVID, as well as in ensuring access to malaria services for the most vulnerable. The government of Vietnam and NIMPI are pleased to host Malaria Week 2020 and the APMEN annual meeting. This year, the APMEN annual meeting provides us an opportunity to reflect on the year gone past, review our progress, identify key challenges, share the best practices, and highlight specific issues for action at the APMA senior official meeting. Why is it unfortunate that we cannot able together in Hanoi this year? The virtual meeting platform allows us to continue our important discussion. I hope that during today's discussion, we can identify priority action that we need to take forward nationally and regionally to keep malaria elimination on track. It's my honor to welcome government officials from National Malaria Program. Productive meeting. Thank you very much.
Thank you very much, Professor Zong, for that warm welcome to Malaria Week 2020 and for your perspective on the role of APMEN and its contribution to malaria elimination in the region, and of course, the contribution of Vietnam to this network. So I would like now introduce Professor Tiki Pangetsu, the chair of the APMEN Board of Directors. And Professor Tiki Pang is an academic and expert on arboviruses and other tropical diseases. He holds a PhD in immunology from ANU and is a visiting professor at the Yong Lo Lin School of Medicine at the National University of Singapore. And he also served as a policy director for research policy and cooperation at the World Health Organization in Geneva. So I invite Professor Tiki Pang to share perspectives on progress made towards elimination and challenges and opportunities presented by COVID-19. Over to you, Professor Pang.
Thank you very much, Jost, and hello to everyone, wherever you are. Let me begin by thanking, first of all, Dr. Dong, NIMPE, and the government of Vietnam for hosting the APMEN annual meeting, Malaria Week, and the senior officials meeting later. We are most grateful for your generosity in hosting this whole week. Let me begin by highlighting the fact that, before the COVID pandemic, we have sort of really made good progress in terms of malaria elimination. Dr. Dong, you highlighted how successful Vietnam has been At the same time, we have seen no cases in malaria and Timor-Leste, and no deaths in Cambodia. And that good progress has been due to efforts around surveillance, around access to diagnostics, to treatment and prevention tools, and also supported by resources that has been available for all these activities. But at the heart of it really is that this success is due to the countries taking ownership and providing leadership towards malaria elimination. And then, of course, against this background of success, we had COVID hitting us at the beginning of this year, essentially. And I would like to think of COVID not just as a totally negative event. Yes, of course, because of COVID, we have seen a surge, an increase in cases of malaria, not just malaria. Dengue is another example. TB is another example. A drop in childhood vaccination is another example, because health systems have been preoccupied with dealing with COVID. But at the same time, it also serves to highlight why the health system as a whole is so important. It has to be able to deal not just with malaria, but with so many other diseases. And in this context, also, COVID has also highlighted inequities, because there are parts of the population which are disproportionately affected by COVID. The vulnerable, the marginalized, and parts of the population who are unable to access healthcare because of the distraction of COVID. So that brings me quickly just to highlight in this context, what might be the challenges in the future for APMEN and its partners to continue this very good progress. Very importantly, once again, because of the importance of health system, the first challenge is to continue to work towards integrated service delivery, to innovate around integrated service delivery in the context of the health system as a whole. And importantly, to also involve the frontline health workers, because COVID has actually told us that the role of the community in terms of surveillance, for example, they are the best people to actually alert you when something is going on. So in a way, we could learn from that as a result of COVID. So the role of volunteer malaria workers in Myanmar, for example, is another good example, which in the future, APMEN will try to perhaps expand to other countries in the region. And finally, as Dr. Dong has mentioned, COVID has also highlighted the importance of the private sector. Okay, it's undeniable that in the COVID response, the private sector has been very central, not just in developing of vaccines, but in developing of treatments as well as rapid diagnostic tests, which, as we know, is central to the malaria elimination effort. So against that background, the annual meeting of APMEN this year will particularly focus on two of those dimensions and challenges that I mentioned. First is how do we work towards better private sector engagement? And secondly, how do we integrate in the future this bottom-up approach, community-based approaches, bottom-up to complement perhaps something which is at a higher level, advocacy, political advocacy that APMEN is doing. So in that sense, that's going to be the focus of the annual meeting of APMEN. And basically, it sort of allows me to highlight the important transition that's going on between APMEN and APMEN. I think in the future, we hope to see further integration, closer connections between APMEN and APMEN, top-down, bottom-up, if you like, and also to make the country work more intentional and more targeted towards engaging and taking into account the priority of the countries themselves. So to embrace integration more closely and to engage more closely with the countries. And finally, also to put into all this a more holistic approach in the two organizations working together, making better links between the technical operational issues that Joost and Dr. Dong has mentioned, together with the policy issues at the higher level of government. So I'll stop there, and just to say that I look forward to hearing during this annual meeting from APMEN's partners on their views, and also once again to really thank them as critical partners for APMEN and APLMA in our efforts to eliminate malaria by 2030. Thank you very much, Joost.
Thank you very much, Professor Pang, for your rich insight into the role of health system strengthening and what it means for malaria elimination, also referring it to the COVID context these days. And I would like now to introduce Dr. Satak Das, the CEO at the Asia Pacific Leaders Malaria Alliance. Dr. Das just recently joined APLMA in May 2020 from the Harvard T.H. Chan School of Public Health, where he holds appointments as a research scientist in both the Dean's Office and the Departments of Health Policy and Management. And he's also a senior advisor for research translation and global health policy at the Harvard Global Health Institute. Dr. Das has over 20 years experience as both a public health scientist and a development practitioner. So Dr. Das, please share your perspective on country engagement for improved health and malaria outcomes. The floor is yours.
Thank you. Thank you very much, Professor Zung and the colleagues in Ninh Pei and the government of Vietnam, and to Professor Pangestu for the opening remarks, and to Joost for already helping us have a smooth presentation so far. I did have some slides, so I'm not sure if we could pull those up, but while we're waiting for that to happen, I really want to thank the Amita Chabi and the team at APLMA and APMEN for welcoming me so far into the work of APMEN, and in particular to inviting me to speak at this event. You know, I think that in my understanding of the history, APMEN predates APLMA. And I think I've been thinking a lot about what that means, and I'll come back to this as a metaphor repeatedly in these remarks, but it's the foundation as far as what I can understand about what needs to happen regionally in terms of malaria elimination, and obviously at a country level, because it produces the evidence, it links the science, and it builds capacity. And so it is very much the foundation on which APLMA relies. And the notion that we can separate these two is really an impossible one. If we could just go to the next slide, please. My presentation is really just three simple areas. And first is really around background. I'm not going to say anything about my own background, actually, because you've already done that. But I did want to say this to further the point around background, that it is not only about the generation of evidence as being the foundation, but ensuring that locally generated evidence serves as a means to build local capacity. And so if we could fast forward to the next slide, and just to add a bit more color, and to many of those who may be wondering, why is someone from HIV and TB now in charge of the APLMA Secretariat? And really, the heart of my experience, I think, putting a vertical disease aside, is to Professor Pangestu's point, coming out and born out of living, for the most part, in the field over the last many years. And if there's anything that has taught me, is that one, ultimately, we have to allow the public sector and countries to lead us. Two, we have to make sure that when we think about vertical interventions, they're always thinking synergistically about how we can use what's on the ground. And three, there really is, no point to such endeavor if it is not always oriented to a point of view that is building capacity, and certainly thinking about building capacity subnationally. Could you please forward to the next slide? So when I think about foundational principles for APLMA, I think I would suggest to the network, or offer to the network, to consider these from our perspective, because in the documents that I've read and what I've been learning about APMEN, these very much seem to be ingrained in the network's philosophy. But certainly foundational principles from my perspective in regards to what this platform offers are around ensuring that all the work is country-owned and country-led, ensuring that the kind of research that happens really prioritizes research of an operational nature that always is linked to capacity building. And as I mentioned, work, because we are dealing in malaria elimination, certainly in a context where most of what we have in terms of areas of higher prevalence and incidence is among those last pockets, among the vulnerable, among to rural people and remote populations, be they people moving in between forests and borders in the greater Mekong, or people living on the islands in Papua New Guinea, or people living in tribal communities in India. I think that there is no path to elimination, as all of you know better than I do, that is the path where we must put an intensive focus to be able to accomplish what needs to be done. And the fourth point is something I'd like to describe a bit more in the next slide, please, because I wanted to speak a bit to, if we could advance to the next slide, how do we actually work together? And so understanding that the foundation of APLMA is APMEN, is data, is evidence. With that in mind, and thinking about how do we work together? How do we do this? I see this really as 4 pillars and a framework for action for APLMA and APMEN together that includes and begins with the generation of local evidence. And really that's the starting point of a continuum that then moves to taking that local evidence, ensuring that it is appropriately socialized, understood by everyone, beginning with country leadership and WHO and other normative guidance of all the other important partners, to be able to then advocate for policies that will result in the necessary resources. But that work for us as APLMA has to really begin in the middle and end with country engagement. There's no way that we can do that in the absence. And yes, we are a regional platform, but to be a regional platform that is viable and can be speaking with credibility and trust within specific countries, there is no other way than for us to build our relationship with countries. And that is through the vital partnerships that this network offers. Next slide, please. So to be specific in regards to COVID, because I don't think it's possible for me to not address this, I think as Professor Pangestu has suggested, rather than seeing this as only a crisis, it certainly provides us with a lot to think about and gives us opportunities in terms of really putting our technical skills, our partnerships together in a way that can serve a dual purpose. Many groups, obviously, including WHO, are leading excellent work around this. So I would say in terms of country engagement, how APLMA and APMEN can work together is not only through the core working groups that currently exist that are critical to the elimination agenda, but to also remain aware, attuned, and attentive to the fact that all these national programs are contending with something that is not going away anytime soon. And so in what ways, what specific ways might we be able to think about a more dynamic, synergistic approach? And these are just some of the ideas that are out there. But I do think in regards to regional level modeling, in surveillance, leveraging new diagnostic tools, in particular, those three, where I see APMEN, APMEN playing a role together is, again, being able to take platforms, convenings, but link them to specific purpose. So it's convening with a purpose, it's platform with a purpose to try and answer specific country needs, see where we can help move the needle around a particular validation or sensitize leaders to some type of modeling work and so forth. In terms of number 4, I think it's critical also for us all to continually push the agenda around program management and building program management capacity, particularly at the subnational level, as a major priority. Because again, as I think the community at large knows, without strengthening program management, we will not be able to sustain the gains made in elimination. And I think many countries, including Sri Lanka, for example, have proven that, or are proving that when you do that, you are able to have a successful response to COVID. And the last point is one that was already spoken to, but again, I think we need to spend a lot of intentional time working together in thinking about that cadre of health worker, that is village health workers and community health workers who have been significantly deployed in national malaria responses. And the only other thing I would add is that we need to be thinking of them always as part of a system, because where that focus can sometimes go wrong is when we don't think of them as part of a referral pathway, which then results in it becoming another siloed layer of the health system. And so moving to the last slide very quickly, I just wanted to, actually, this is not the last slide. The last slide, yes, just very quickly, thank you. Wanted to close by saying, I do think that this provides us with an unprecedented opportunity, that is the pandemic, to really think about what we mean when we say capacity building and to build a new paradigm for capacity building. Because we're no longer in an era where we're going to be, at least we're not in a time at the moment where we're all sitting together around a table in a convention hall. And I think in the years to come, this could enable us new ways of thinking about how we build capacities that are those kinds of bridges that are made out of roots that will stay over time. So thank you very much for welcoming into your community, and I'm looking forward to the day's session.
Thank you very much, Dr. Das. And thank you to actually all the speakers for setting the context for the APMEN annual meeting and providing a framework for the 2 sessions we have lined up for you today. We will now move into our first working session for the day on private sector engagement for malaria elimination. Just one sentence again about the mechanics, because many people have just recently joined. So I want to remind you all maybe to use the speaker view. That will give you the best experience. So you will see actually the speaker in a large screen. And also please make heavy use of the chat box. We like to hear your comments, your thoughts, and you just write them in the chat. And I have seen some wonderful discussions going on in the chat box. So please share and do not hold back. So now I have the pleasure to actually introduce you to your chair and moderator for the first session. Her name is Sandy Nguyen. She's no stranger to many of you. She's an international public health specialist and has worked for more than 20 years across 6 regions. She founded the Myanmar Health and Development Consortium in 2012, and she's also serving as a senior health advisor to APMEN. Formerly, she worked for the Global Fund, World Bank, UNDP, and many other international organizations like the IMF and the National Network of Asian and Pacific Women. So I hand over to Sandy Nguyen and I'm looking forward to very interesting discussions because we have an excellent panel. Sandy, over to you.
Thank you very much, Josh, for the warm introduction. And a very warm welcome to all the participants to this session, where we'll have APMEN country partners share their experiences with private provider engagement. The presentation will then be followed by a panel discussion. A key objective of this session is to share recommendations for policy processes at the APMEN Senior Officials Meeting which is scheduled for Friday, September 11th, and we very much welcome your feedback. Due to time constraints, as Jos has mentioned before, we may not be able to have a Q&A session today, but we encourage you to use the chat box below so you can share your comments and feedback. Over the years, private sector engagement has been identified as a critical area by APMEN partners as we journey towards malaria elimination. In most parts of Southeast Asia, private providers are often a major, if not a primary source of provision of healthcare, including for management of febrile cases, also related to malaria. For the purpose of this discussion, the private sector is defined as any facility, outlet, or individual offering health information, products, or services that is not managed by the government. One of the objectives of this session is to provide a platform for the national malaria programs to share information and exchange experiences with private sector engagement from their own country contexts. We will start this session off with country presentation from Indonesia, followed by Myanmar, and we'll see whether Afghanistan can join us. We will begin with the presentation from Indonesia and I would like to introduce you to Dr. Didik Budijanto. Dr. Budijanto is the Director of Prevention and Control of Vector-Borne and Zoonotic Diseases at the Ministry of Health in Indonesia. Previously, he served as the head of the Center of Data and Information at the Ministry of Health. And he also graduated from Faculty of Veterinary Medicine and got his master's in public health and PhD in public health from Airlangga University in Surabaya. Without further ado, Pak Didik, please proceed with your presentation.
Thank you, Sandy. Yeah. Good afternoon, ladies and gentlemen. It's an honor for us from Indonesia to share our experience in public-private mix in Indonesia and the role of industry association towards malaria elimination. First of all, let me wish you all of to be always in a good health during this COVID-19 pandemic. Ladies and gentlemen, this is malaria. I think I would like to have Dr. Helen to share. Yes, this is malaria situation in Indonesia. Out of 514 districts, 16% have received a malaria elimination. Currently, there are 23 districts, 4%, which are still high endemic area. The endemicity of malaria shown on this slide is low, medium, and high endemicity, respectively indicated by the color difference, namely green, yellow, and red. And you can see that the colorlessness are malaria-free areas, and currently 79.9% of Indonesian population left this area, they are already malaria-free. Next. This slide shows that the challenge faced in malaria control in Indonesia today. There is stagnation in detection of malaria cases, decrease in cases caused by the COVID-19 pandemic. The graph of left shows there's decline in malaria cases from years to years, which all actually decrease the majority of cases outside the Papua province. However, there was twofold increase in case detection in the Papua region based on the annual blood examination rate, ABER. With this increase in case detection, case reported in Papua also increased. In 2019, 86% of cases in Indonesia were reported from Papua province. The graph on the right shows a decrease in case finding or more than 15% compared to this case to the case finding that in January until June 2020 due to large-scale social distancing during the COVID-19 pandemic. During the COVID-19 pandemic, several adjustments were made so that mitigation activity can continue with the implementation of health protocol. With the circular from the Directorate General regarding protocol that must be carried out as a reference in carrying out prevention and control activity of the malaria program during the pandemic period. The protocol on malaria prevention and control during COVID-19 pandemic issued by Director General of Disease Prevention and Control on 23 April 2020, which includes the first adjustment of COVID-19 screening flow in malaria endemic area to include malaria screening. And then adjustment of malaria service in the health facility to use RGT to reduce crowd, and adjustment of epidemiological investigation by health staff and active case finding by community health worker to use PPA during field and home visit. Adjustment of LLIN campaign to limit crowd in distribution point by 10% maximum, or conduct the LLIN campaign through door-to-door distribution. I think next, yeah, slide. The slide shows that national plan, yeah. The national plan, action plan for acceleration, yes, of malaria elimination 2020 until 2024, highlight the importance of private sector and engagement in all four strategies. We have four strategies: territorial, yeah, and yes, I continued. Yeah, the second increased its number of malaria-free districts from 285 in 2018 to 405 by end 2024. The third, malaria-free status in maintained is district which have been awarded malaria-free certification. Additionally, there are four strategies with one, universal access for the malaria case management and prevention. The second, surveillance, escort intervention of malaria elimination, and the third, improve enabling environment to ensure malaria elimination achievement, including through PCC and community engagement. And the fourth, strengthening the health system to deliver malaria elimination program. That's a public-private mix is a component in all strategies. Next. In Indonesia, this public-private partnership has been going on for a long time in the region. The slides show best practice in the form of partnership on malaria control program with British Petroleum in Bintuni District, West Papua. This is the best practice one. Yeah. The malaria team of British Petroleum integrate with the malaria team of District Head Office and together strengthen the case management. The process was carried out. The pharmacy and transit ACT, a malaria medicine, to be given to the community or cadres with an introduction from a doctor and a result from a malaria blood test. and an activities case finding was carried out as well by cadres. As a result of this collaboration, the API decreased from 114.9 per mil in 2006 to 5.5 per mil in 2012 and even to 26 in 2016. This program received a public service award from the United Nations in 2018. As a good practice second, next, the slide describes the partnership with the Sumba Foundation in Sumba Region, the East Nusa Tenggara Province. The Sumba Foundation built a microscopic training center. The training carried out was basic malaria microscopic training was held for 2 weeks. This was a collaboration between province and district health office with the Association of Indonesian Medical Laboratory Technology expert in the province. Next. The third best practice, another sample of good practice that can be lesson learned in the partnership of the malaria control program with the private sector in Manowari, West Papua for quality assurance and standard treatment. You can see the flow of government-private partnership service on the left, and the right slide show the signing of the MOU between the head office and private pharmacies that can provide malaria drugs according to standard. And the evaluation of partnership, next, with a private pharmacy in the Manowari district, West Papua. The following is an evaluation of the best practice carried out in Manowari in the previous slide. In the evaluation of government partnership with private pharmacy in Manowari Regency, West Papua Province, it can be seen that an increase in services for malaria patients, existing malaria drug and private pharmacies in 2019 compared to 2018. Although there has been a slight decrease in the number of private pharmacies involved. As a lesson learned, next, ladies and gentlemen, based on this practice base, we can conclude that the private sector is a potential partner in achieving malaria elimination and should be involved in a call, killing, intervention in all phases of malaria elimination, from acceleration, case reduction, to maintaining malaria elimination, benefiting from this public-private partnership. And the second, partnership can work well if the private sector is closely involved with province and district head office, and all cases are reported in the malaria information system, which accommodate private service reporting. And the third, public-private partnership network in the management of quality malaria cases. The private sector is given free ACT drug and participate in the capacity building of resources carried out by the government. With regard to gap and opportunity in malaria control program in Indonesia, the point are the first one, Indonesia has a large area. Therefore, the management of private sector still heavily driven by local initiative. And more systematic management will be orchestrated by the Ministry of Health at central level to support the initiative in a local level. The second is, Indonesia is applying decentralized governance system. The success of partnership depends on the leadership and arrangement at the strict level to the governance system, the success of partnership. These practices have been demonstrated effort to studies and evaluation support by practice is still limited. I think let me conclude my talk by thanking you all for your kind attention. Thank you very much.
Thank you for the very interesting presentation on private-public mix for malaria in Indonesia, Pak. Our next presentation today is from Myanmar. I would like to introduce Dr. Wimpyo Tha, Deputy Director from the VVDC program in Myanmar. Dr. Wimpyo Tha received her MBBS degree from Institute of Medicine 2 in Yangon in 2004 and completed her MPH from University of Public Health in 2013. She also studied International Field Epidemiology Training Program in Thailand from 2016 to 2018. She has over 11 years of experience working in the field of malaria. She is now serving as Deputy Director, VBCC, Department of Public Health in Ministry of Health and Sports in Myanmar. May I now present Dr. Wimpyo Tha.
Good afternoon, everyone. I am Dr. Wimpyo Tha from Myanmar, and on behalf of Myanmar NNC National Malaria Control Program, thank you very much, APMEN, for providing an opportunity to show Myanmar case story on engagement or private sector engagement in malaria. I will capture the engagement in few slides. Next slide, please. Myanmar is the second largest country in Southeast Asia with about 52 million population residing in 15 states and regions that comprise 330 townships. The country is bordering with Bangladesh, China, India, Laos, BDR, and Thailand. Out of total 52 million population, 22.3 million population are at risk of malaria. 53,000 cases and 14 malaria deaths were reported in 2019. 60% of malaria cases was Plasmodium virus in 2019. Primary vectors are Anopheles direct and Anopheles minimax. The slide shows the trend of malaria case and death during 2005 to June 2020. The decline in case and death are striking. Next slide, please. In 2019, next slide. In 2019, Myanmar reduced 89% malaria cases and 97% malaria deaths in comparison to 2012. The success factors are huge network or 21,000 frontline health workers and private outlets, wider coverage of long-lasting insecticide treatedness, quality sure diagnostic, microscopy, as well as RTT and anti-malarials. National program was able to provide equitable malaria service that have reached to all parts of the country and cover risk population like forest goer and mobile and migrant population. Malaria services are being provided by over 30 partners, which also include the private sector. Last but not the least, funds were available to carry out program activities. Thanks you to the generous donor and also to technical assistance of WHO. And next, please. The timeline for malaria elimination is 2030, and Plasmodium falciparum elimination target is by 2025. The private sector is crucial to fight malaria and achieve these targets. With this in mind, Myanmar has developed private sector engagement guidelines to guide the sector for national malaria response. Next, please. 65% of malaria cases in Myanmar are reported through private sector. Of these, 54% seek care from the private sector. There are over 80,000 medical doctors work as private practitioner during 2013 to 2014. This number have grown in recent years. As shown in the slide, private sector in Myanmar is comprised of general practitioner, hospitals, non-health sector, etc. There are numerous projects operated by private sector like artemisinin monotherapy replacement and M2030, which bring business, consumers, and organizations to defeat malaria. Next, please. The slide shows the contribution of private sector in different areas. In 2019, 1,400 trained private providers conducted 236,000 tests and detected 2,300 cases. These practitioners notified 522 cases to National Malaria Control Program. The private providers are also supported in removal of oral artemisinin monotherapy from the market. In 2019, the availability of oral artemisinin monotherapy was 5% in comparison to 67% in 2012. Private sector are also supporting National Malaria Control Program in LLIN distribution. Moreover, private sector are also engaged in generating evidence for effectiveness of insecticide-free clothing and repellent, which will be important to address outdoor malaria transmission. Next slide, please. This slide shows the National Malaria Control Program's malaria data flow by types of providers. The malaria volunteers enter the NNCP and partner, and the private providers need to mandatorily submit malaria report to the designated focal point of healthcare facility. Then the data flow to the central level through the dedicated channel. I would like to draw your attention to the black box where the data flow within the private provider are highlighted. The data is linked to the National Malaria Surveillance System at various levels as shown by the blue solid line and dashed green line. Now we are using paper-based reporting up to the township level. At the township level, the data is entered via the computerized system and sent to the NNCP server. The data from this server can be accessed by township, state and region, and central levels. We would like to mention that National Malaria Control Program has developed a web-based reporting system. This system will provide access to the private provider to submit data through the web-based system. And next slide, please. I would like to cite a specific example of one of the projects SMS for Life undertaken by UMFCCI Myanmar jointly with National Malaria Control Program. The objective of this project is to engage non-health private sector to support malaria control and elimination. More specifically, to develop comprehensive corporate sector engagement strategy, implement public-private partnership activity, use innovative technologies and expertise to the private sector, and engage private sector business to become active partner in malaria elimination and promote CSR. Mobile for Malaria component introduced award-winning SMS for Life platform, which is shown in the slide. This is used for timely reporting of case investigation, case management, and stock management situation at MOHS facility. Deployment of ICME and website volunteer level. Integrate with fast-moving consumer goods, delivery component for transport of essential supply to MOHS facility. The project worked with volunteer, website, and real health center. The data on case and commodity generated by these channels are transmitted to the cloud server. The data from the cloud can then be accessed by the basic health staff, township health department, as well as the central level. And next slide, please. This challenge and way forward, there is a optimal engagement of private sector in malaria fight in Myanmar. The program has vision to expand the private sector network to include 100% of the provider in years to come. This will include both health and non-health sector. However, the challenge of financial and human resource to engage this sector will remain. Moreover, some of the high malaria burden are still present in non-government control area, and there will be operational difficulty to reach to this private sector. Program will work with ethnic health organizations in this area. It is equally important to regulate these private sectors. Finally, I would like to mention that National Malaria Control Program will work with WHO and partners to fully implement the private sector engagement guideline. We will work together with private sector to achieve malaria elimination. And next, please. We acknowledge the generous contribution of private sector in the fight to end malaria in Myanmar. We look forward to stronger collaboration in days to come. Thank you very much for your kind attention.
Thank you for the very interesting presentation on private sector engagement, Dr. Wimpyo. I think the two country presentations have provided a good context for our upcoming panel discussion. As we've heard from our government representatives, there are various approaches to engaging with the private providers. Having said this, I think we could do a lot more. This is particularly critical for the Asia-Pacific region. In order to achieve elimination, countries need to manage and report all malaria cases, which requires engaging the private sector, and particularly where the private sector is already providing a significant proportion of the healthcare. In this panel discussion, we'll be highlighting some of the experiences from implementing partners, share information on the kind of support available from partners to NMCPs to develop private sector engagement plans, learn from other diseases such as tuberculosis, as well as other peer-to-peer collaboration models from our partners in Africa. So without further ado, I would like to start this session by introducing our panelists. We're honored to welcome our colleague from Zambia, Dr. Mutenda, Acting Director of the National Malaria Elimination Center in Zambia. Dr. Mutenda joined the malaria program 6 years ago and has a rich experience of working in Zambia. Our second panelist is Dr. Kemi Tesfagi. Dr. Tesfagi works with Population Services International as a program director of Gates-funded GEMS program. In her current role, she provides leadership to ensure that the program objectives of transitioning private sector network oversights to NMPs is achieved while ensuring high-quality, evidence-based implementation and documentation of all technical aspects of the program. We also have with us Dr. Badri Thapa, malaria scientist with the WHO Country Office in Myanmar. He works very closely with the Myanmar National Malaria Control Program in support of their malaria elimination goal. Finally, we have Mr. Anna Pal. Mr. Pal is a senior manager at Clinton Health Access Initiative, or CHAI, leading some of the tuberculosis private sector engagement projects in India. We just heard from Dr. Wimpyo on the experience in Myanmar. So building on that presentation, my first question is directed to Dr. Badri Thapa from WHO. Dr. Badri, WHO plays a critical role through its country offices to support the national government in developing appropriate health policies and guidelines. Can you share your experience with supporting the NMCP in Myanmar with developing private sector engagement guidelines? What do you think were the critical areas of support that you were able to provide? And can you walk us through the steps involved in developing and finalizing national private sector engagement plans?
Thank you, Dr. Sandy, and thank you, APMEN, for providing this opportunity. And also, it's good to be here to support and complement Dr. Wimpyo from NMCP. She already highlighted some of the engagement in the private sectors in Myanmar. And she also mentioned the target for malaria elimination is by 2030 and PF target is by 2025. And this is also based on the numerous targets that we have with us. And WHO's main support to NMCP is setting the malaria policies and strategies, and importantly, developing important documents that support implementation of these strategies and policies. And private sectors, as mentioned by Professor Tiki and by Dr. Das, and also in Dr. Winfrey Than's slides, we are clear that they play important role in the malaria fight in the country and also in Myanmar. And she also clearly mentioned that 54% of the febrile illness access service to the private providers. And now National Malaria Control Program is making malaria notifiable disease. So this means that all private sectors need to mandatorily notify to the health authorities. And even the zero reports need to be submitted to achieve elimination. And with this background in mind, it is important to have a private sector guideline in place that will guide the private providers to help the NMCP to fight malaria in Myanmar. And as Dr. Sandy asked me to go through the step-by-step process, I will enumerate few steps now. So it was in the country, it is very important to buy the process, buy in the NMCP's they need to be in to develop this guideline, and NMCP was engaged and they had a good leadership and also saw the ownership of this development process, and they were fully engaged and steered to the entire process of this development of the guideline. And Dr. Win already mentioned that private sectors are engaged in numerous activities, and we didn't start from scratch. We just built on the existing experiences. And we know that there are a lot of private partners working with the private sectors. And one of the important partners is Population Service International. So WHO and program jointly engaged PSI to engage over 400 private providers on the malaria test, trick and track services. And these projects include mapping of the service providers and developing inventories and select private providers based on the set criterias and also based on their consent. And we had an assessment, baseline assessment on their knowledge, attitude and practice on malaria. And training curriculums were developed based on those and trainings were provided. And finally, they implement a set of activities that was supposed to be a part of the guideline. And after implementing this project, so the draft guideline was developed that was comprehensive enough, outlining the steps for the engagement, and also include number of tools that would be required by the local health authorities and also by the partners. And after the draft was ready, so the draft was consulted in a larger forum with the expert in Myanmar, as well as the local program officers at state and regional levels, and also with the partners working in Myanmar. And to highlight WHO's support on this initiative, the support is clear that we support NMCP in developing the National Strategic Plan that is inclusive of private sector strategies and interventions. And we provided a technical support and also a financial support to have this project in place, and also to support the development of this guideline. And last but not the least, that Bill Gates Foundation was generous enough to support WHO and program to have this project that led to the development of the private sector guideline. Thank you, Sandy.
Thank you very much, Dr. Bhatri. We all recognize that private sector is also a multi-partner, multi-sectorial initiative. Implementing partners such as PSI have played an important role in supporting national governments in taking the first step towards engaging private providers. Kemi, can you share some of your highlights of PSI's experience in the Greater Mekong sub-region through PSI's GEMS program? And specifically, what are some of the areas of opportunity with respect to private provider engagement? And what are the challenges that you see?
Thank you, Sandy, and thank you for the opportunity to be part of this panel. As you know, PSI implemented a private sector engagement program between 2016 and 2019 in Cambodia, Laos, Vietnam, and Myanmar. The objective of the program was to increase coverage of quality malaria services within the private sector by helping them provide quality testing, treatment, and reporting according to national policies. What the GEMS project demonstrated for me is that it is possible to engage a wide range of private providers, both formal and non-formal, and help them to provide quality malaria case management. Now, throughout the life of GEMS project, over 3.5 million tests were administered by the private sector providers. Over 96,000 cases were detected, and those were reported into national surveillance health systems. At the highest point of the project, we had over 25,000 providers enrolled in the project, and they were accounting for about up to 40% of national testing and caseload in the countries we worked in. Now, we achieved this incredible result by working in strong partnership with national programs and partners like WHO as well, to map the providers, to provide comprehensive training, to ensure a solid supply chain of commodities, to monitor quality of care being provided, to also make sure that the reporting systems were adapted and aligned for integration into the public's surveillance system. In my experience through this program, what I've seen is that the private sector engagement works best where you have strong partnership with the national programs and other stakeholders, and where there's a clear vision of how the providers, the private sector providers, engage in the malaria elimination agenda. That's why I'm quite excited about the next phase of the GEMS project, where our mandate is to work over the next 3 years with the NMPs in these 4 countries to transition oversight of the private sector to their management. Thank you.
Thank you, Kemi. I would now like to turn to Dr. Mudenda for a perspective from the National Malaria Elimination Center in Zambia. Dr. Mudenda, can you share a bit about your experience with private sector engagement? And do you have a private sector engagement plan? What has been the highlights and what are some of the challenges in your opinion? Do we have Dr. Mudenda online? Okay, can we, maybe I'll skip to the next person until she returns. Okay, let me now turn to Mr. Anna. Mr. Anna, India has launched a very ambitious private provider engagement plan through its National Tuberculosis Control Program. I understand that one of the foundational building blocks for this program was the development of an electronic TB case notification system that could be used by private providers. Can you tell us about the private provider engagement strategy for TB, and also specifically share your experience with integrating the public and private case reporting system?
Thanks, Dr. Sandy. So for India, I think there has been a massive shift in how private sector engagement has played out over the last few years. The country's strategy has evolved from initially it was, the messaging to private providers was you need to refer the cases to the public program. Over the last few years, we've seen that evolve to let the private providers manage the cases themselves, and the program will provide access to drugs, diagnostics, and all the necessary support so that patients get effectively managed in the private sector. So with this change in the strategy, messaging, and mindset of the program, I think there have been few key interventions which the government and the program has taken. One, as you rightly mentioned, has been the development of online patient management and tracking surveillance system called NICSHARE. Besides that, the government's also identified that to scale up private sector engagement, there's need to engage with agencies, NGO partners, and others to scale up the program. So there has been a few new models which have been developed in India, wherein intermediary agencies actually act as facilitators for private sector engagement. And the third key initiative taken by the government has been direct cash transfers or conditional cash transfers to providers and patients to engage with the program and ensure that services are being provided. If I talk about, the electronic case management system or the Nikshay system, it's been now last 3-4 years back, the system was developed by the government of India. The Nikshay system has both a mobile application as well as a web application. So it can actually be used directly by private providers, to notify cases. There are multiple ways in which providers can notify. As I said, they can use the mobile app themselves. They can call up a call center and notify, or they can send the information to the district program officers to notify cases. So providing a plethora of options to providers to notify kind of actually helped in improving access and ensuring that providers would notify cases. Additionally, the Nikshay system also simplified reporting. It provided easy access to information. It helped patients being tracked, longitudinally from point of diagnosis, treatment till completion. So, in terms of data management, surveillance, I think this system has obviously kind of improved access to information at all the levels, from district, sub-district level to a national level, and provides real-time information on what's going on. However, I think in terms of lessons learned and in terms of what's working well with the Nikshay system and what could potentially be done better, I think one of the challenges has been that right now the system is kind of an add-on to the paper-based management system which also exists. So for a lot of program staff, they look at this Nikshay system as additional work because the paper systems exist, and on top of it there is the electronic system. So if you really want to drive adoption, and I think there needs to be a plan to kind of slowly move out or stop paper-based systems and migrate completely to electronic systems. From a private sector standpoint, I think while this is a comprehensive surveillance system, expecting them to fill up all the data points, make sure that tracking takes place, it is sometimes challenging. Providers are happy to share basic information, but refill information, adherence data, all those become challenging for providers to kind of maintain and track. So providers need support, and that's where intermediary agencies come into picture. What they do as part of the program is they engage with providers, they sensitize them about TB diagnostics. They provide access to private sector patients to quality assured diagnostic tests and drugs. So at the end of the day, the providers only need to they can manage the case, and all the services in terms of drugs, diagnostics, follow-up services are provided by the program through these intermediary agencies. And finally, I think there is a need to invest in training of program staff as well as providers on these new systems, because any electronic system keeps on evolving over a period of time, and there's need for kind of continuous upgradation and training of program staff to make sure that the systems can be used effectively on an ongoing basis.
Thank you very much. Can I just perhaps give you another follow-up question? You mentioned the move out of paper-based to electronic reporting system. How long did it take, do you think? Because I think a lot of countries are challenged by that aspect.
It's still not completely transitioned. So as I said, it's been 3-4 years Nikshay system has been used, but currently also there is both the systems kind of exist in parallel, the paper-based as well as the electronic systems. Although I think compliance and usage of the Nikshay system has improved significantly, as backups, the paper systems are still maintained. So it is challenging. It's never easy to kind of completely transition off to electronic system, but I think India's pretty much on its way and in the journey towards that towards that end objective.
Thank you very much. I believe our colleague from Zambia is in the room now. So can I turn back to Dr. Mudenda for her perspective from the National Malaria Elimination Center in Zambia. Can you share a bit about your experience with private sector engagement? And do you have private sector engagement plan what do you think have been the highlights and what are some of the challenges in your opinion? Dr. Mundenda.
Good afternoon, everyone. And I want to begin by saying thank you very much for inviting me to be part of the panel discussion. I'm honored. Our experience here in my country is that we do not have a private sector involvement policy, but we do work with the private sector. And we are still in the process of coming up with an actual policy. An example that I can give in terms of case management. In the past, when we would form the new guidelines and we're doing trainings, we would only do it with the public health sector, but now we do it even with the private facilities. And I have to emphasize that the situation in my country is that I could say almost 90% of the facilities are public, because we only have private facilities in the more urban parts of the country, while in the rural ones, we don't have those because people just don't have the money to start going to pay to the private ones. So the few private providers in terms of case management are the ones around the capital and in the bigger provinces. So they make up just about 10 to 15% of the overall provision of malaria case management. But we have found a way of integrating with them in that when we update our guidelines, we make sure that we distribute even to them so that as they manage the cases, they follow that which we have put in our guidelines. And now we have managed to include them when we're doing certain on-site technical supervision and maybe proficiency training in microscopy. We've managed to include them. Of course, the challenge that we meet when we're doing that is that it's difficult for private providers to give you their lab personnel maybe for the whole week, because the training is for the whole week, because they are more commercial based than the public sector is. But we do manage to provide that supervision and assistance to make sure that the level of provision of service is at the same level that we have it in the private sector. We have also collaborated well with the private sector when it comes to vector control. And notably, when the country first began the indoor residue spraying campaign, the IRS, it was in the year 2000, and it was actually the mining companies that began it because they had noticed a lot of mosquitoes in their area, a lot of malaria, and it was impacting their productivity. So they began to spray their communities. And then bit by bit, even government joined in, and now it is a nationwide kind of activity. And even to date, we do collaborate in vector control activities with the mining companies and the bigger companies such as the sugar companies, many of those that have got a lot of workers and they feel the impact when their workers have got malaria. So that collaboration, sometimes it's in the form of the mining company doing in the malaria spraying, the IRS, not only in their compound, but in the district within which they operate. And then there are times when it is a situation where they may not be able to find all the chemicals, but the government can give them the chemicals and then they provide the manpower with their own manpower. Other times the collaboration is in the form of when we have a training, we get even those spray operators from the mining area and incorporate them. So we do work hand in hand. Is it without problems? No, it does have problems, like I mentioned, especially on the case management part, where it's difficult to get people who are in an income generating kind of a mode to come to away from their operation for a while. In terms of data, we're still in the process of checking how to get more of the private sector providers to get their data into our health management information system. As at now, we have the data from those that are private but non-profit, mainly like the mission hospitals. These tend to from the government and they do get the drugs from the government. But for those that are acting totally independent of the government, we are still in the process of finding out how to integrate their data into our data. So for now, perhaps that would be where I can end. Thank you.
Thank you, Dr. Mundenda. You mentioned, let me just ask you a follow-up question. because you mentioned about mining companies and sugar companies. And it is great to work with them when malaria is endemic and it's high and it's affecting their workers. What happens when we are moving towards elimination and these companies are not seeing cases anymore in their own workers or workforce? How do we continue to convince these companies that elimination is just as important?
What we have done is we have come up with something we're calling the End Malaria Council. And in that End Malaria Council, we have incorporated the big mining companies, we've incorporated the sugar companies, so that we have shared the vision to say this is where we're going. And when the cases do get low where you are, we still need to do the surveillance to make sure that we know which cases are endemic and we are still doing the reporting, and that we avoid coming back like resurgence of the malaria. So we have co-opted them in at their highest level into a body that has been charged to help with eliminating malaria in the country. So we have that buy-in. I could even mention that some of the companies are even helping to sponsor adverts on our behalf, because we have put them in one united body where they know that the aim is to eliminate malaria. So there's a feeling of wanting to be seen to be part of the malaria fight. So that is how we have gone around that.
Thank you very much. So we have hope then to continue working with the big CEOs and the big companies in the private sector for elimination purposes.
Yes, we do. And we have certainly told them to say that when malaria, if they eliminate malaria where they are, but it has not been eliminated around them, it will certainly come back. So it is to their advantage to help keep it out, not only where they are, but everywhere else, because we know that malaria does come back if the neighbors around you still have it.
Thank you very much, Dr. Melinda. I'm now going to turn to Kemi and talk about private providers. So Kemi, there's a widespread perception about private providers being primarily profit-seeking and driven only by financial incentives. Does this resonate with what you've seen from the GEMS program? And what are some of the approaches you use to motivate private providers? Whether it's around improving quality of care or ensuring regular, timely reporting?
Thanks, Sandy. When I'm asked that question, I'm often tempted to reply tongue-in-cheek that we're all motivated on some level by financial incentives. But on a serious note, to unpack that perspective or that perception a little bit, in PSI, we conducted research in 2018 and 2019, looking at the providers in the 4 countries where we work and exploring what factors motivated these providers. So in the quantitative aspect of this research, over 900 providers were surveyed. And these group of people who are looked on as solely financial motivated were motivated to do a good job because of 2 groups of factors. So the internal factors and the external factors. So for example, the feeling that my reputation depends on doing a good job is an external factor. And interestingly, we found that external factors such as those were linked to financial motivations as well. So if I'm more driven by external factors or motivated by external factors, and the chances are I'm also more motivated by financial factors. An example of an internal factor is a slightly more seemingly altruistic one, where I'm motivated because I want to take part in elimination of malaria in my community or in my country. We also found that these factors had regional variations within a country and across countries as well. And they were interlinked with each other. So it's not as easy as saying they're only motivated by finances or not motivated by finances. What we also did find in Myanmar and Vietnam, the Myanmar and Vietnam arms of the study, is that internal and external motivation scores were associated with a willingness to remain in the program, so to keep doing malaria elimination activities, even after partners like PSI exit and stop providing, support. So the findings were not as simple as finance or no finance. They're context specific within and across countries. Now, the qualitative aspect of the research also showed us some interesting things. So similar to what the presenter from Indonesia talked about, there's the desire to access free or highly subsidized commodities. There was also the desire to have continuing professional development, because from the perspective of the providers, especially in the GMS where national treatment guidelines change because of drug resistance, being engaged in programs like the ones delivered by PSI was the only way for them to keep their practice up to date and their training up to date. At least that's what they reported. And then they also valued the opportunity to interact with their peers in the community or within their catchment areas and across. So we have both quantitative and qualitative factors that push us to understand the more complex nature of provider motivation. And then the final point around the financial motivations comes from what we call the ACT Watch surveys. So they're outlet surveys that with the main objective of looking at the availability and price of RDTs and ACTs in outlets. And these were conducted across numerous countries over multiple years. And what we found was that in certain contexts, the providers who are engaged in programs like the ones we delivered in PSR are less likely to overcharge for services than the providers who are not engaged, right? So we've used this insight, one, to improve our programming. So having aspects of the programming that build on these complex motivating factors, but also to advocate to governments as well for more strategic engagement of the private sector, as opposed to outright bans of the private sector because they're financially motivated. Now, I'll stop here. I recognize I've thrown a lot of data and information out, and I invite participants to reach out to me if they want to explore in more detail the data or some of the work that we've done to respond to this. Thank you.
Thank you, Kemi. I think what you've said about provider motivation factors are really important. It's poorly understood, and I think there's a big gap between the understanding between the public sector and the private sector. So I hope you can continue to advocate for that. Let me turn to Dr. Bhatri now. Dr. Bhatri, an important question that comes up is around the effective governance of the private sector. From a WHO perspective, how should NMCPs be thinking about governance and policy change with respect to private providers?
Thank you. Once again, I think this is an important area. So, and also effective governance is all the more important. And as you all know that this is one of the important building block of the health system, as well as the community systems. I will draw your attention to the different documents that are published from the published in malaria by WHO. So we have our global technical strategies and the Greater Mekong Sub-Region Malaria Elimination Strategy and Malaria Elimination Framework, the Malaria Surveillance Manual. And we also published a Malaria Partnership Guideline in 2006 that talks about the governance as well as the policy change that the program needs when we engage these private sectors. And importantly, based on these global and regional documents, Myanmar has already developed the National Strategic Plan, which is already under implementation. And country has also developed the next strategy for the next 5 years. And the private sector strategies and interventions are clearly reflected in this document. And this is not standing alone, but these are built on the existing overall national health policies, as well as the National Health Plan for 2017 to 2021. And private sector has been clearly recognized as one of the stakeholders in implementing the health and including malaria in the country. So this means that there is a high level commitment from the government side to engage these private sectors as well as a service provider in the health. as well as malaria. And as I mentioned earlier, that malaria is going to be a notifiable disease in Myanmar. So all sectors, including private sectors, need to contribute to this notification. And overall, this notification law will be under this Myanmar Communicable Disease Law. And as you mentioned, that the effective private sector governance require more policy change. So I will be speaking based on what Kemi mentioned from PSI, that there will be a need for key policy change. I will just put it into 3 bullet points. First is the recognition of the private sectors, whether they are formal or informal. The country needs to recognize them for malaria engagement and also need to recognize their contribution. That would be important step forward. And second is on the regulation of the private sectors. There should be clear policies on the registration of the private sectors. I'm not talking about the registration of private sectors with the for health within the Ministry of Health, but there should be registration of these private sectors with the local malaria authorities. And this would be policy signing of the memorandum of understanding with the local malaria authorities. And accreditation will also be important. That will help private sectors to gain trust from the public, and on the regulation bodies strengthening like FDA. And clear policies on the sale of RDTs and anti-malarials in the open market in the private sectors. And importantly, the quality assurance aspect of this regulation, which is a good supervision, monitoring, and with the check and balances with the private sectors. And when we talk about the corporate sectors, and the corporate policies also should be in place, and malaria should be incorporated into their health programs. And third one is, once we have a legislation, once we have a regulation, but if we don't provide them some enabling environment from the private sectors, then the legislation will not work. And this is also important in the context of what Kemi mentioned, the motivation to the private sectors that will keep them engaged despite of the projects, for the longer term engagement. And the policies are needed in terms of providing an environment to build the capacity to work properly for the malaria test, treat, and track services, including other service. And this need to be equipped with free or subsidized RDT and drugs. And that is also important in terms of providing tools for reporting and notification. And Pranab already mentioned that the TB program has a long experience in India in engaging the TB service provided through the NICHE portal. Similar level of platform would be required in Myanmar if we need to move this forward. And Myanmar is already moving ahead in this dimension. And lastly, under this enabling environment, the financial incentive is important, but it is not the end. So there should be some non-monetary incentives in place, like providing opportunities for them for the professional development, and also organizing some continuing medical education sessions funded through the program. And lastly, on the engagement in the national and international malaria engagements, that could be a bigger meeting, which is not yet there. So thank you, Sandy.
Thank you, Dr. Japa. Let me now turn to Mr. Anna. I think private provider engagement is believed to be quite resource intensive and costly. How is a high burden country like India financing the private provider engagement for TB? And what do you think is the path for sustainability?
So thanks, Sandy. I think it's a bit of a fallacy that cost of private sector engagement is really high. And I can quote some numbers actually. I think some studies have been done which have shown that, let's say, the cost of engaging private sector for TB notification is in the range of around $90 to $100 per notified case. And in India, the cost, if you look at the national TB program, cost per notified case is around $150. So, I think the cost of private sector engagement is probably in the same ballpark or similar to cost of treating TB in the public sector in that sense. But yes, it definitely means that if you have to engage private providers, there is need to kind of invest additional resources for doing that. In India, as I mentioned, the approach which is being taken is hiring intermediary agencies and contracting out intermediary agencies to undertake this engagement on behalf of the program. So India has increased its budgetary allocation for TB program by almost 3x over the last 4 to 5 years. So it's increased from around $250 million to around $750 million in the last financial year. And that has been possible because of, I think, sustained political commitment to end TB, eliminate TB by 2025. And most of this increase in budgetary support is directed towards private sector engagement. So how are these resources being used? As I said, I think the government's now moving towards contracting of agencies to undertake private sector engagement. Historically, or till very recently, a lot of these projects were funded through donors like the Global Fund. Over the last 1 year, the government's launched a new partnership guidance document which espouses and talks about how do you engage with private sector providers, how do you get intermediary agencies on board to undertake private sector engagement. So that I think the policy framework is now in place along with the national strategic plan to kind of undertake these contracts with the private sector. Additionally, the nature of these contracts are more output-based contracts. So it's the agencies get paid only when they achieve certain targets which have been set for them. And otherwise there are penalties and other clauses. So this kind of addresses or kind of balances out the risk for the program as well. It doesn't lead to significantly high payouts if achievements are low in that sense. And to enable this contracting to kind of actually take place, the government's also I think there's a lot of emphasis on building capabilities at the provincial level for the state governments to actually contract these out. Service contracts are typically fairly complex and a lot of government agencies struggle to do that. So I think there's a lot of emphasis on building contracting capacity and capability so that such contracts can actually be rolled out and agencies can be brought on board. The World Bank has also, is providing support to the National TB program, and there's a 7-year grant, a 7-year loan which has been approved through which the World Bank is also providing and establishing technical support units to enable state governments and local governments to build this capacity and contract this out, this work to agencies in the future. That's all. Thank you.
Thank you very much. Maybe I can ask the last question back to Dr. Mundenda. I know you mentioned a bit about vector control and the role of private sector. Did you want anything more to add, for example, perhaps vector control activities or partnerships for vector control, tools such as IRS or BetNets or other tools that you have in mind? Maybe not. I think we lost her again. Okay, I believe we have time for some Q&A directly from the chat room. So we will get some questions filtered out and will be directed towards our panelists. So just if you could wait for a few minutes, we'll be right back with you. Okay, there's a question for Dr. Wimpyotha from Myanmar. What percentage of RDT testing and malaria positive cases treated were from the private sector for 2019? Dr. Wimpyotha, can you answer that question?
Yes. From the private sector, there is a 5.4% of the positivity rate in 2019. The tested is approximately there is 10% of the tested rate, and the positive rate is 5.4%. Case detection is 5.4% contribute in the whole country data.
Okay, thank you. Please stay on the line because there are more questions for you. There are informal private providers widespread in villages, especially hard to reach areas. So the question is, are they already included in the forces fighting malaria activities?
This data include in URC data has included informal private sector, and also PSI data. There is a outlet private provider. It means the actually the not formal private sector. So we have a partial engagement of this informal private sector.
Okay, thank you. Here's a third question for you. From recent experience working with private GPs, it was challenging to get them to report malaria in a timely fashion using ODK application. Do you have any ideas of how they can be better motivated to engage in the malaria elimination effort?
Up to now, the private sector, general practitioner use the SMS and by the PSI and the mail reporting by the MMA, use the positive case notification by SMS and email.
MCNet သုံးတယ် MCNet with it or GB clinic တွေကို in Sakai region မှာ test we are state testing.
OTK is we are state testing in Sakai region and Kachin State by the MC and Malaria Consortium here.
Okay, thank you, Dr. Wimputa. I think the next question is for Indonesia. The question is there a plan to impart mandatory case notifications in Indonesia? Pak Didak, are you still there?
Yes. Okay, thank you very much. Maybe I would like to ask my colleague to help me and to respond. Dr. Helen, please. Dr. Helen. Yeah. Sorry, Sandy, because I'm a new director in here, so maybe the technical about the program of malaria is Dr. Helen can follow until now. Yeah, Dr. Helen.
Maybe we can get your responses in writing, and we will feed it back to the people who are asking the questions.
Yeah.
Thank you.
Thank you very much.
Another question for Kimmy. Are those formal and informal private providers, do they reach forest goers? Is the question.
So where we've been able to collect data on the breakdown of the professions or activities of the clients, we found that between 60 and 80% of the people who the providers are testing are either forest goers or plantation workers.
Okay, there's a question for anybody who would like to respond. It's a question on vector surveillance and control. So the question says, we've had very little specifically about how the private sector has been or could be engaged in vector surveillance and control. Can the panel discuss the role of the private sector in the delivery of vector surveillance and control? Any takers? Well, let's have this be answered in a written response then. Thank you. Let me go to the next question. Again, a generic one. How can we convert the vast number of untreated mosquito nets in the private retail sector into ITNs? Any ideas? Okay, well, let's go to the next question then. This is for Anna. It says, I know that some country government programs and leaders worry about proliferation of third-party groups, like intermediaries for PPPs, as Dr. Anna just elaborated, concerned that this increases the cost of delivery and may only be sustainable with external financing. What if it dries up or decreases? Will they remain viable?
Thanks, Sandy. So yes, I think that's definitely a potential concern where such interventions or such intermediary agencies are externally funded or donor funded. In India, as I was mentioning in my earlier question, the government is moving to actually contracting out these agencies directly through domestic funds. They're kind of moving away from externally funded agencies to agencies which are contracted out through a competitive selection process to provide these services to the private sector. That in a way makes it sustainable, because going forward, the government is going to use its own resources to get these agencies on board. In terms of whether these interventions are more costly versus, let's say, providers directly notifying or engaging with the program, there might be various models to actually, for private sector engagement to work. I think in India's experience, in country experience, we've seen that getting agencies on board helps in rapidly scaling up engagement. Because engaging private sector requires sustained efforts. It's not like a one-time effort. The program's also trying to provide access to drugs and diagnostics to the private sector. So someone has to do that. Typically within the program, there is not sufficient capacity to do all these external additional tasks. And that's where getting an agency on board kind of helps streamline and make sure there's some bit of quality and that's available and is provided to the private sector. And in terms of cost effectiveness, as I mentioned, I think as per some studies, the cost of engaging private sector through intermediary agencies is around $100, and whereas the cost of treating in the public sector is around $150. So I would say it's more or less in the same range. It's probably not significantly more expensive than treating public sector patients.
Sandy, this is Tiki Pang here.
Yes,
I'm not on the panel, but could I just contribute a comment?
Please.
Yeah, my comment is related to your earlier question about the role of the private sector in vector control. Okay, I just want to share my own experiences with vector control for dengue. Okay, and in the context of Singapore, for example, one of the main private sector sources of mosquito breeding is the construction industry. Okay, so in countries where there's a lot of construction going on, that part of the private sector is potentially an important source for mosquito breeding. Now, obviously, you could appeal to these companies and say, hey, you must do your part to make sure that, you contribute to vector control. But I think it's a combination of both the carrot and the stick. Like in Singapore, for example, if any of these private sector construction companies are actually caught not providing good control for mosquito breeding on their work sites, they can actually be ordered to stop work. Okay, the government has legislation to enable that to happen. Now, I'm not saying that you could sort of do the same in the context of malaria. It's just that there are many ways of getting the private sector involved. Obviously, it's better for this to be voluntary, but at the same time, if they are directly contributing, like in the case of these construction companies, then I think you also perhaps need a more sort of legislative kind of approach. So just a comment to contribute to the discussion. Thank you.
Thank you, Professor Tiki. I think this is a very good way to end the session. I would like to thank all the panelists who've been here and participated at this session. At this time, I'd like to invite Amita Chepi, Senior Director of APMEN, to share a summary of the discussions for this session and any specific recommendations that were highlighted as priority actions for the senior officials meeting that's coming up on Friday. Amita, over to you.
Thank you, Sandy. Wow, what a fantastic session. And I can really feel the energy in this virtual room. So welcome, everybody. I'm really missing being able to see everyone here today and remembering the last APMEN meeting in Bangkok last year when I got to meet most of you for the first time. So hoping that there will be a in-person meeting next year and that we'll be able to catch up. But thank you for making the time and joining us here today. Earlier this year, the APMEN Secretariat identified private sector engagement as a priority area of work. And this was really driven by the feedback we'd received from country partners who said that this is a significant challenge on their journey towards elimination and identified this as a place where they wanted more support. Now, we knew that a lot of the countries were already engaging with the private sector in some shape or form. So we commissioned a review to really look at what was out there in terms of existing tools to work with the private sector, alternative approaches and models that were being used by country partners to engage the private sector. And the result of that review is a report that we're launching today. This is a private sector engagement framework report that APMEN has developed, and we're sharing the link with you here in the chat box as well. The objective of this report is to really provide a framework for national malaria program managers that are starting to think about private sector engagement. And what it aims to do is really distill a lot of the experiences of partners in this space, whether it's country partners, implementing partners, guidance from the WHO, and all of that is really in the form of this easy to use framework that countries can use. I'm going to try and summarize some of the key points from today's discussion. It's a really rich, lively conversation, and I think it's given us a lot of food for thought on how to take this forward. As you all know, one of the main objectives of the APMEN meeting is to really identify priority actions that can then be taken up for further conversation at the APMEN senior officials meeting. So what we're going to do is condense a lot of the conversation here and try to identify a couple of key recommendations that we think would benefit from the attention of senior leaders at the SOM. The first one is, I think, very clearly stood out through the presentations and the panel discussion today, was the need to develop a private sector engagement plan. Now, like I said earlier, a lot of our countries are already working on this in some shape and form, but there is a real need to bring all of this together under one umbrella in the form of a strategy or a guideline that is really informed by the national strategic plan of your country, that can be used to advocate for resources for further private sector engagement, and really be a plan against which you track progress around how you work with the private sector. Now, obviously, this plan will look very different for different countries. because it needs to be tailored to a specific country context. It depends on your epidemiological situation. It depends on the health system that you have in your country. It depends on the social context. And of course, it depends on the resources that are available. So each country needs to develop its own customized country plan. I think we found this resonated in the presentation from Indonesia as well, where Dr. Didik really presented how they're thinking of private sector engagement in Indonesia. And the one point that really stood out was the fact that given their decentralized health system, they're thinking about private partnership with the private sector really at a district and provincial level. So yes, you have a national plan, but what's more important is really thinking through how does that translate into a subnational strategy or a subnational plan? And I think that's going to be really critical for several of our country partners. Coming to the second point, this is really around, and again came up in almost every conversation today, was the need for an integrated surveillance system that gives you a comprehensive view of the public and the private sector. Now, we know that there's several contexts where the private sector accounts for a large proportion of care seeking by patients. So in such a context, if you're looking only at the national surveillance data, you don't really have a true picture of the malaria burden in your country. And this is going to affect the way you think of allocating your resources more efficiently, as well as making sure that as well as unfortunately not being able to prioritize action for effective response. So really need a comprehensive public plus private view of the data. And I think the Myanmar example by Dr. Win Phyo Than really showed us that there are easy ways in which you can integrate the two together. And of course, this will again look very different from country to country, but you can use a combination of electronic and paper-based reporting systems. We saw that even from Mr. Arnab Pal's presentation and the TB experience in India. You can look at a combination of using community volunteers as well as public health workers. You can look at different ways in which you aggregate the data, whether it's at the district level or at the national level or at the subnational level. So lots of permutations and combinations that are on offer here. And I think countries need to think through what's the best way that they want to really start integrating some of this data. Coming to the last point, and which is probably one of the most critical ones, and which we hear from partners all the time as being one of the most important stumbling blocks around private sector engagement, is the issue of quality of care. And as we heard from Kemi and her experiences, with the PSI GEMS program in the GMS, again, there are some ways in which you can work and engage with the private sector to improve quality of care. This can be done through adequate training, providing commodity support to private providers, mentoring, and I think most importantly, making sure that they see themselves as being part of a partnership with the national program. This was reflected in Dr. Badri's remarks as well, the fact that you need to recognize, I think we cannot anymore continue to turn a blind eye to the private sector and the role that it plays in the national health system. Need to recognize the private sector and then find ways to engage with them most appropriately. Even as I say that, I know that with the increasing prevalence of VIVACs in the GMS, the issue of quality of care becomes significantly more complicated. This is because of the fact that you need screening for G6PD deficiency. The treatment protocols are much longer. So quality of care becomes a very thorny issue in that context. But our VIVACs working group within APMEN has been having several discussions on this matter. And this is again an area where we would continue to encourage engagement from all our partners. So thank you for this incredibly lively session. I think there's like I said, a lot of food for thought. We would encourage you to share your comments and feedback in the chat box. The idea is to distill a lot of this and share it in the form of recommendations to the senior officials. Thank you.